Welcome, everyone. Five Wishes is pleased to present today's Practice Community webinar, Advanced Care Planning Perspectives and Best Practices, a roundtable conversation. My name is Jennifer, and it's my pleasure to facilitate. We are recording the call, and we muted all participant audio. If you need help, please email 5wishes@compartners.com. That's the number 5wishes@compartners.com. This presentation will last up to 60 minutes, and you are encouraged to ask questions throughout. Simply click on the Q&A button at the bottom of your screen. A separate box will open where you can then type in your questions. It is now my pleasure to turn this over to Joanne Eason, President of Five Wishes. Welcome, Joanne.
Thank you, Jennifer, and thank you all for joining us today for the 10th Five Wishes Practice Community webinar. Five Wishes started 25 years ago with the idea that people should have a voice in their care at the end of life, and that it shouldn't be difficult for that voice to be heard. Advanced directives then, and some now, were hard to understand. And Five Wishes, well, the whole idea was to make it easy. And that's the idea behind our practice community. It's to make it easier for you to have the resources available to assist you in doing advanced care planning on your day-to-day basis. And it's also here to help you have truly meaningful conversations with the people that you serve. We do that not only through our program resources, but mainly through sharing best practices, innovations, and highlighting thought leaders. And speaking of thought leaders, we are honored today to have the group of people that we do, the preeminent thought leaders and experts in the field of advanced care planning, and that they're gathered around this virtual table to help share ideas to inform and inspire the work that you do every day. So we're very grateful for them, and we're grateful for you for all the work that you do. So I'd like to introduce Kathleen Taylor, who's going to moderate today's conversation. Kathleen serves as our Five Wishes Healthcare Advisor, and she brings nearly 3 decades of experience in hospice and palliative care focused advanced care planning, program development, patient care, and communications. So Kathleen, thanks so much for making this webinar a reality.
Thank you, Joanne, and thank you everyone who's joining us today. Just as a reminder, if you have thoughts or questions during our discussion today, please click on the Q&A button at the bottom of your screen and submit whatever it is that you'd like to add. The Q&A input is going to be moderated and captured today. So if your question or input isn't addressed during the webinar today, we'll follow up with you afterward. And now onto our program. Whether or not you read medical journals or listen to palliative care podcasts, you're probably aware that advanced care planning is enjoying a period of critical thought and consideration right now. On the one hand, it's been required in some value-based models because of its benefits, and on the other hand, it's been criticized as ineffective in some research reviews. So there is indeed a lot to talk about, and we welcome the conversation. This discussion today is going to focus on what works, on best practices, adding value to the patient and clinician experience, and what advanced care planning should mean and include in order to be effective in the evolving healthcare environment. And we have with us, as Joanne said, several experts in the field who think a lot and know a lot and influence a lot about all of this. So with that said, it's my pleasure to introduce our panelists today. Great, you can all start your video. First, we have Dr. Stephanie Anderson. She's the Executive Director of Respecting Choices, an internationally recognized evidence-based system for person-centered decision-making that transforms the healthcare culture by honoring an individual's goals and values. Respecting Choices is a division of CTAC Innovations. Dr. Anderson has more than 30 years experience in hospice and palliative care, home care, case management, and emergency medicine. Welcome. We have Dr. Stephen Buchanan, who's co-founder and chief medical officer of Iris Healthcare. Iris, powered by Aladad, partners with primary care physicians to scale the delivery of personalized, expert-led, comprehensive advanced care planning. Dr. Buchanan is a palliative medicine physician, was the CEO of one of the country's most successful accountable care organizations, and has started and directed several palliative care programs across the country, including University of Miami's Medical Center, University of Utah's Medical Center, and Ascension Health's largest palliative care program. Welcome. We have Tori Fields. She's the founder and chief executive officer of Votive Health. Votive Health helps health plans and providers deliver high quality care to people with serious illness through value-based agreements, facilitating better payer-provider integration. She also serves as strategic advisor to the Coalition to Transform Advanced Care. Her experience includes work as an economist and population health researcher in a variety of settings. She's an internationally recognized thought leader in value-based care and payment models for people with complex and serious health conditions. Welcome. We have Paul Malley, who is now serving in his 20th year as president of Aging with Dignity, the nonprofit organization that created the 5 Wishes program. As a national expert, speaker, and advocate for quality and dignified care at the end of life, he's guided the efforts of several aging advocacy groups to improve policy on advanced care planning and patient rights, served on the Florida delegation for the White House Conference on Aging, and has testified before state and federal legislative bodies in favor of patient-friendly policies. Welcome, Paul. Dr. Diane Meyer is Director Emerita and Strategic Medical Advisor of the Center to Advance Palliative Care, a national organization devoted to increasing access to quality health for people living with serious illness. Under her leadership, the number of palliative care programs in U.S. hospitals has tripled since 2002. She's a professor in the Department of Geriatrics and Palliative Medicine and the Catherine Gaisman Professor of Medical Ethics at ICANN School of Medicine at Mount Sinai, and co-director of the Patty and J. Baker National Palliative Care Center. Welcome, Dr. Meyer. And we have Dr. Rebecca Sudore. She's a geriatrician, palliative medicine physician, and advanced care planning researcher. She's the founder and director of Prepare for Your Care, an interactive web-based program that includes easy-to-read advanced directives. The program prepares people and their surrogate decision makers to communicate their wishes and make informed medical decisions. She's also a professor of medicine in the geriatrics division at the University of California, San Francisco, and director of the Innovation and Implementation Center in Aging and Palliative Care and the Vulnerable Populations for Aging Research Core of the NIA-funded Pepper Center. Welcome, Dr. Sudore. Thank you, everybody. We're so glad to have you all here. And now to get on with our program. I'd like for us to start with probably one of the biggest questions we might get to today, which is really defining advanced care planning. Given all of the attention with the criticisms and looking at what works and what doesn't, there's been, this has been the subject of much thought and some debate in recent months. So if we think about, I think everyone here can probably agree that good advanced care planning is not check boxes and just aiming for completed advanced directive forms. I think we've moved past that as being what anybody would aim for. So when we think about good advanced care planning, when we think about the parts of it that work, how can we arrive at some kind of definition that helps people understand what is the thing that we're talking about doing with folks? And I'd like to ask Dr. Sudore to start us off, because you've done so much work in this regard, looking at the definition of advanced care planning. Are you all right with that?
Sure, yeah.
Great, thank you.
Well, and I'm also very interested to hear what other people have to say, but I think for your listeners to know, I think what's interesting, you were talking about the evolving healthcare system. I would say this is evolving, and the definition of what advanced care planning is evolving. We had pulled together probably 50 different international experts on advanced care planning back in 2017. And we realized quickly that we actually convened them for something else, about outcomes, which we might get to later today. And we found out that we had to kind of stop what we were doing because these experts on advanced care planning couldn't agree on a definition. So we came up with a preliminary definition, but that was in 2017. And I can tell you that that's still been evolving. I can tell you very briefly how I define advanced care planning, and then I'd love to hear from other people. So I think simply advanced care planning to me is preparation for communication and medical decision-making, with a focus really on who that person is as a human being, what brings them joy and pleasure in life, and how they can sort of use that to make informed decisions for themselves or for other people to make decisions for them. So that's how I think about it. It's really about that preparation.
Oh, I love it, Rebecca. We completely agree. We see the definition evolving and preparing to make medical decisions. I would add to that the process of ongoing communication, and it being about conversations and communications, and whether that's a digital experience, an in-person, virtual, whatever the modality is, but it's a process of communication that includes understanding. It includes reflection and discussions. So not only just writing a name of a healthcare agent down, but discussing with that person so they're well prepared for that role, thinking about what attributes make a good healthcare agent. It's not necessarily your spouse or your family member. It's somebody that can make decisions on your behalf in difficult situations, emotional situations, and are going to elevate that individual that they're making decisions for, their goals, their values, their preferences, rather than their own preferences for that individual. So I think our expanding thinking is that process, as well as the definition to include more than just the individual, but the people that surround that individual that are important to them.
Mm-hmm. Anyone else?
I think there needs to be some degree of healthcare literacy woven in here, because we've got lots of studies with when people have serious illness and they feel as though over 70% of people with incurable cancer feel like they may be cured, right? And it's not because they're going to go to Hogwarts hospital and be treated by Harry Potter. It really is because we use language that patients and families don't understand from the get-go. People hear the word treatment and they equate that with the word cure and so forth. And so I think there has to be some foundation in the process where patients and families have an option, an ability to learn more about their illness and what we expect to happen over time as that evolves.
And that would be, to Rebecca's point, part of preparation, I would hope. I wonder if I can, oh, I'm sorry, go ahead.
I really appreciate that point, Stephen. I think I definitely don't have the expertise in parsing through the definitions of advanced care planning like the others on this panel, but from not only is this definition expanding and changing and evolving, but healthcare delivery is expanding and changing and evolving. And the treatments that people get and the choices people have to make are becoming much more complicated due to medical innovation. Yay us, right? Yay healthcare. But that actually means that it really changes what informed consent and what treatment options mean for people. And so when I look at something like advanced care planning, I think about it as planning in advance for your care. And if that is the truth, then we may be making very different decisions every time we receive care, depending on what it is, depending on how we feel, depending on a lot of different things that are just not medically related at all. And that means that it really needs to be a conversation and discussion between you, your community, whoever that might be for you, and with your treatment team, who is going to do whatever decisions they need to make for your care. We often put advanced care planning into this box of somebody who is seriously ill rather than thinking about somebody who has to make care decisions. And you just have to make more and more of them when you're seriously ill. It's not that the process is really any different.
I think that's a good point, Tori. And one of the things that that I find a bit sometimes confusing is when experts in the field draw a line between serious illness conversations and advanced care planning conversations. And I understand that there are some areas of difference. When a person has serious illness, of course, there are pieces of that conversation that are going to have to do with diagnosis and prognosis and with making appropriate medical recommendations. But my experience coming up doing this, with hospice in the 90s and 2000s was really that was part of advanced care planning with anybody who was seriously ill. So I'm confused with what seems like a boundary between this is an advanced care planning conversation, this is a serious illness conversation. Is it just words at this point? I mean, the things that work, I think, are going to become the definition of what we want people to be trying to do. So again, what are the things that work? Preparing people for decisions, preparing people for the realities of some of those decisions. But is there also a role for people who aren't seriously ill yet?
I would say yes. And Kathleen, you mentioned some of the early days and early years, and hearing some of the first comments today made me think back to when we were first creating the 5 Wishes program in the late 90s. It was standing on the shoulders of that groundbreaking support study from the Robert Wood Johnson Foundation that I think inspired CAPC, Respecting Choices, many other programs that were aimed at trying to close the gap between the dissonance between what people said they thought they wanted at the end of life and what they were actually getting. And when we tied that to our own mission and what we see as a common uniter among all of us, that we have this united desire to take good care of the people we love, I think across the board. Our friends, the people who we're committed to or have a responsibility to, our patients. And we saw how difficult that is when people feel like they haven't been able to do that, when there are family disagreements, when there are disagreements inside medical facilities. So I think when I think about what is advanced care planning, and also the difference between advanced care planning discussions and serious illness discussions, it's, are we moving people closer to that place where they can feel like they can say, yes, I took good care of the person who I love the most, and fill in that gap. For us, what we've seen is that does include naming a decision maker, but also not stopping there, because we've also over the past 20 years received a lot of phone calls in our office from people in emergency rooms who say, my mother named me as a healthcare agent and I just found out, and now I don't know what to do. I know I'm the decision maker, but I don't know where to start. So I think the magic that we've always looked for, and why I think it's so useful to have this groups together, is to find that sweet spot of how to have conversations with people today so that they can be ready to be a good caregiver or a decision maker, patient, whatever the case might be, to give that good and right and best care at the right time. And I love what Rebecca said about finding what brings joy to a person, because we also tried to pull that out in discussions of what good caregiving looks like, and who a person wants to be with them, and those sorts of things. And although that's not the kind of the biggest flag that flies on the advanced care planning radar on the clinical or legal perspective, I think that's what matters to people and families and friends and caregivers. So I think good advanced care planning combines those things together in an effective way.
Yeah, and I think conversations early, conversations with someone's healthy, when they're young, when they've got nothing going on, I think even though it may not directly relate to goal concordance of care right at the end of life, I think that's all part of the preparation, Rebecca, that you're talking about. If someone has the experience of talking about their values around end of life, of even exploring what the options are with some regularity, my belief, and I think what I've seen, although it's certainly hundreds of anecdotes, is that that does prepare people in some way for making those decisions when somebody in their family or when they themselves become ill. So I'm hoping that we can define advanced care planning still as something that's relevant across the lifespan and across the care continuum. And that is going to lead me into another area that I want to talk about, which is professional training. If we keep in mind the things that work and what we hope people are doing, which is preparing all the people that we're talking about for making these decisions and what the realities might be, how do we train those of us who might engage in these conversations to have them well? And Stephanie, I'm wondering if you'd be comfortable starting with that, because respecting choices is probably, it's the most widely known training program out there. And we frequently hear people say that they use the respecting choices approach, which I know is very much about staging these conversations depending on where a person is. But what do you think the competencies really should be if we're going to be training people to do it well?
Well, thanks, Kathleen. I think there are several variables in consideration. One is a multimodal approach. The second is I wouldn't put the umbrella just over professional. This can be a team approach, including community-based organizations. We've seen amazing curricula using the Respecting Choices model in faith communities, for example, in trusted communities, communities of color and their faith trusted leaders holding these educational courses for those that it's appropriate to move this conversation upstream, as you've been talking about, that don't need the medical expertise in having conversations with a healthy adult, and the opportunity to help people learn how to listen first before teaching. So listening and learning from the individual, exploring what matters most to them, what cultural, spiritual, personal beliefs would impact their medical care as they're thinking about preparing for care. I think another important component of the training is that if you have a skilled individual, whether that's a clinician or non-clinician, journeying with an individual on through a conversation, that individual becomes empowered to advocate for themselves in a way that might not otherwise happen. And so when you think about training, there are so many dimensions to it. There's the how to have the conversation. There's training on the system changes that need to occur. So a conversation in a faith community gets documented and accessible to the healthcare team that would be providing care. There's the component of people that have a serious illness, and that then needs an additional component of training and how to walk with people about helping, do you understand about your serious illness? How is that impacting your life? What is living well to you mean now with a serious illness? And we would advocate that training includes, this is a point I try to make often, because we disagree with treatment menus in conversations and training. And so having a serious illness training that focuses on a conversation that is helping somebody to think about what an acceptable or unacceptable outcome of care is to them, rather than specific treatment options related to whatever decision they might be faced with in the future, which is really impossible. So I guess I would summarize by saying multimodal, multi-audience, not just education for having the conversation, but the system pieces around that make the conversation, that education stick and work for the patient. And then finally, we have found a couple outcomes in our curricula. One is that you can't just do asynchronous or toolkits and expect profound behavior change. There really needs to be a component of a competency-based skills acquisition, role play practice. We hear so many people say, I'm so uncomfortable doing this. And by the end of practicing, they have that comfort level that is now going to have behavior change. And so thinking about that, again, speaks to that multimodal and then scaling strategies. So it has to be accessible, affordable, and scalable to the masses that are interested and willing to be able to support the people they're caring for in these ways, whether that's in the community or in healthcare. Thanks.
Sure. Stephen, you train your facilitators with IRIS. There's an intensive training there, and what they're doing, just to be clear, is really disease-specific comprehensive advanced care planning. So it's in that serious illness conversation, disease-specific realm. What are the competencies that you're training them to?
Yeah. Well, let me just say, I'm a Respecting Choices graduate and eternally grateful. You all were doing that before anybody else had anything to offer like that. And it's just had a huge impact on my life and I think millions of other people. And so thank you, Stephanie. And Stephanie was one of my course instructors back in the day. Yeah, so I think at IRIS, just there's certainly a lot of common elements to what Stephanie just went through. I would add, we're big on evidence-based communication techniques, and this is something. So I did palliative medicine training. I went through Respecting Choices and CAPC courses and so forth. This is something that I didn't get a lot of exposure to myself until later in life, and so that's negotiation, conflict resolution, demonstration of empathy, active listening, motivational interviewing, and so forth. There are these really rich techniques that we can use and apply to the rest of our lives, right? I use that with all my kids, use that with our animals, certainly use it in my relationship with my wife and friends and so forth. That is a big part of what we do with the IRIS training. But I think that the other component here is everything that we do is recorded. And there's a number of reasons for that, but everything we do with patients is recorded. And I'm a big proponent of, if you're going to talk to people about this stuff, record it. And we may talk about that later with standardization and so forth. But what this allows us to do in terms of training is create master facilitators, right? Because I cannot tell you how many people we've all trained collectively here on how to have conversations with patients and families. And the reality is we cannot be in the room for all of those, right? So we have 3 or 4 trainees on our team. They go out and see the whole list of patients. We can only be in one place at a time. So we weren't in the room to see the facial expressions, to hear the tone of people's voice, to hear the words that they use. So we record everything, every single thing. And in terms of training, we go back. So our folks are on training wheels. And so this is part of the mentoring program that we have. And we go back and we first ride shotgun to all of their facilitations. And then even when the training wheels are off, we call it ears on. We're an ears on company. Like, we are listening. Even when you're considered to be a master facilitator, because we can all get better at this over time, and we all need somebody to help us improve our communication skills continuously.
I love that. We can always, we do always keep improving. I think these are skills that are deeply rooted. And as you said, useful in every aspect of life. Diane, I wonder if I can ask you, CAPC has so many materials and resources about communication, also about advanced care planning and serious illness conversations, but really communication overall. And I'm just wondering how you see this definition of what we should be training people to, what the competencies should be.
It's a great question. Let me first say thank you to Respecting Choices, because our advanced care planning content is advanced care Respecting Choices content, and our communication skills content is, as they say, powered by Vital Talk. So we collaborate with the experts in the field and don't try to reinvent the wheel. I would say the biggest barrier to initiating these conversations for clinicians, aside from time, which is a huge barrier, is this feeling that you're signaling to the patient that you're worried about them and that you think they might die. And we don't want to scare our patients, and we don't want them to feel like afraid to come see us for fear we're going to hang crepe. And remind them of things they just as soon not think about, like most of us. So my view is that the critical teaching is the routinization of these conversations, like seatbelts, bicycle helmets, vaccines. And that's where I have the conversation, in that part of the discussion. So do you always wear your seatbelt? Have you been to the dentist? When was your last colonoscopy? And then I say, I discuss this with all my patients. Have you thought about who you might trust to make decisions for you if you lost the ability to make your own decisions? Like I am literally checking off a list. And by routinizing it, the valence, the fear valence goes down. Yeah. And for both, especially for the clinician, because the clinician anxiety is the barrier, but also for the patient. I discuss this with all my patients, not just you today, because I can see the writing on the wall and you're going to be dead within a year, but everyone. So I think that's a very key message. You know, we would never consider seeing a patient without checking the blood pressure and the pulse and the weight and, you know, organizing the medication list and the problem list. We need to make this as core and routine and boring as everything else we do in an encounter, as opposed to something that has a drum roll and basses playing because of the clinician anxiety largely. Oh, so that's the first thing. The second thing is, and everyone on this phone call knows it, it's very hard to honor patients' wishes in a healthcare system that only pays for acute care, essentially. And the number of patients I've had who said, I never want to go back to the hospital, I want to receive care at home, but they're not eligible because they don't have Medicare Advantage, or they're not Medicaid, so no one's willing to pay for home care. The family member is exhausted and stressed, and at 3 a.m. they call 911. That is a system failure. That is not an advanced care planning failure. So that is my belief. That is why we can't show outcomes from all these advanced care planning studies. It's not that there's a problem with the advanced care planning. It's that the healthcare system only delivers a glide path. And particularly for very vulnerable and sick people, their wishes are a very frail reed against the financial infrastructure and delivery models of the healthcare system. And in a sense, I feel like that's where our attention should be. It should be on basically what Tori is doing, which is trying to create a community-based care infrastructure and to help payers as well as health systems think about that without the open faucet of hospitalizations in terms of money. That would really honor people's wishes way more than getting them to say what they would like in an ideal world. It's not an ideal world, and they're very likely not to get it because of that. And that's what frustrates me. It's like I feel like we're talking to ourselves and not talking in the real world. So that's the first thing. The second thing, again, everyone on this call has seen this, is the way in which someone like me might say, really, if I was significantly cognitively disabled, I really wouldn't want any continued life support. I'd want care only focused on my comfort. That's what I would say right now. I know and have seen enough times people just like me change their mind when the alternative is death. And so this notion that somehow what gives me joy and what I believe now has real salience for unpredictable future events in unpredictable future contexts, I think there's no data to support that. That people are incredibly resilient and they shift what's acceptable based on the reality they're in. We don't have rigid autonomous preferences and choices. We adjust. Look at all the people who are paralyzed from the neck down who would rather live now. They adjusted. Life is precious. There's still a lot of engagement and joy in it. Whereas from where we are right now, we'd say, no, 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 that's not a life worth living to me. And we shouldn't ignore that reality. And one of my concerns is that we convey to patients, and I think this is why some patients are so resistant to this process, because they know they don't know what they would want in an unknown future. And they're right, and we're wrong, right? They're right. They know that perspectives and choices and priorities change when circumstances change. And advanced care planning has a very difficult time recognizing that reality. And therefore, what I do in my practice is that I discuss this with all my patients. Who would you trust? And go into a little more detail on who that person can be, and that we have to talk to them. Perhaps they could come in at the next visit. And then the second piece is I only ask one thing about their preferences. And that is, if you were to walk out of my office here today and be hit by a truck and be permanently brain injured and cognitively impaired such that you could no longer recognize and interact with your loved ones and weren't expected ever to be able to do that again. So basically in a vegetative state or a permanent coma. I then say some of my patients say in that situation, they would want care focused only on their comfort. But others of my patients say life would still be worth living to them in that situation. They would want continued care focused on keeping them alive. Which kind of person are you? So I am not judging the I want everything done group. I'm offering it as an equally valid choice. Some of my patients say A, others say B. Which kind of person are you? And the patient can't pick up a judgment from me, hopefully. When I say, and that's enough, that's it, those two things. I think you could get a lot of clinicians to do that because it's pretty simple and pretty straightforward and probably 5 to 7 minutes if we were consistent and standardized in how we trained at the medical school and residency level and nursing school level. So that's my speech on advanced care planning.
It was lovely. And I really appreciate what you said about the routinization of these conversations. And a lot of what you said is the same language we have in the 5 Wishes conversation guide for clinicians, which is about the whole idea is if you're not going to get training where you can do the role plays and really get comfortable with this, here's just a simple guide and some things to say. And one of them is, I like to have this conversation with all of my patients. So I think in addition to having it be routine, having it be regular, because people change their mind and because their social support system changes and because they may have had experiences with somebody else who's ill and they've learned something about what they're afraid of, or they want, or they don't want, to have these be regular and routine. We've got points of care all over the place where these conversations could be revisited. And I'm really hoping that what people understand going forward about advanced care planning is that it's never done. It's not done. You can't say I've done it with this patient, and so we don't need to look at that again. It just means we need to revisit that pretty much every time there's some kind of shift in this person's life. So I liked all of that for training, and I want to move us on to talking. Oh, I'm sorry. Go ahead.
I was just going to make another point, because I think it was really important that Diane brought up, which is this idea that you can change your mind. And I feel like we don't tell patients that. I think we tell patients it is a one and done thing. And we don't tell people it's a process. We don't tell people, hey, we have this conversation now. You could change your surrogate decision maker tomorrow because something changed in your life. You could change how you feel, and that's normal. That is a human process, and we'll go through the process together. But I think we need to educate clinicians, but we also need to educate patients that that's part of the process.
Yeah.
By making it more routine, Rebecca, from that perspective, then you're able to actually leave the clinician's office and have a conversation about what your cultural preferences are, what your family's preferences are, and you're able to come back as a more informed decision maker the next time around. And that's something that often is missed in these conversations, because you're only having it once and right when you need it, or you're only having this conversation introduced because somebody is diagnosed as ill. And so then it becomes a situation where you're forced to have to make decisions in this one situation without the ability to consult others or to really reflect on those things. And every day is a new experience, and it becomes something where it's very difficult to have these community activities around advanced care planning where people are teaching one another, or they're documenting 5 wishes alone without a clinician present, because they don't have that in their regular workflow, in their regular routine. And that makes it really difficult for folks to understand, clinicians or patients and families to understand how to use these tools. So you have to be really educated in order to even know how to use these tools. Whereas, I think I have shared with the 5 Wishes team earlier, like I have a routine conversation using 5 Wishes with my nieces and nephews who are children. And as part of that, they also understand that this is something that that is part of life, and that it can change over time as they grow older, right? But if you're only asked that one time, it becomes a situation where you're forced to make decisions.
Mm-hmm.
And that's beautiful to hear, Tori. And I think the connection between all of those comments is that it sets the frequent context, sets the context, and also the motivation. It answers that question of, why is my doctor talking to me about this? Or why is my husband or wife asking me about this? And I think that sets the bridge that if we don't set it, then it's an automatic barrier that we can't get past step 1. And setting that context and motivation, I think is critical, because otherwise you can't move beyond it.
I want to move us forward by blending 2 areas that I had originally thought of as separate topics, but I kind of want to mush them together now, not only in the interest of getting to them with the time that we have, but also because I'm starting to think during this conversation they're really highly related. One of them is measures and outcomes. We talk to so many hospitals and health systems and clinics at 5 Wishes. And I think everyone on this call knows that if you've seen one advanced care planning program, you've seen one advanced care planning program. Generally, systems struggle with what I would call ownership and leadership. Most programs are not truly programs. They're mostly intervention based, and there lacks a programmatic support for doing these things. But what drives program support is the measures. If people can't make a case to their organization about we should invest in this, then they can't get the systems in place to do the work in the way that we are talking about. So my two-pronged question is, what should we be measuring? And how can we measure things that can help us put systems in place that encourage and support clinicians in having the conversations in the ways that we are talking about today? I don't even know who to start with. I'm just going to let anybody who's got something to say chime in.
I'll jump in. We've had a focus on system redesign forever because without that, the conversations, as I said earlier, sometimes don't mean anything because they're siloed and nobody knows about them and they're not transferred, et cetera. So I'm actually going to flip. Kathleen, you talked about measures first and system, but I'm going to actually talk about the system because the measures then I think work to support evaluating that system. And so from a framework standpoint, we have a philosophy of freedom within a framework. So the framework is the system that through evidence and experience, et cetera, seems to work. And then the freedom to adapt to the individual organization, the culture, et cetera. So from a system standpoint, thinking about two components within whatever system you're implementing, that a health system, a single health organization, an entire state of organizations working together. There's a component of wide implementation that spreads across all, and a component of deep implementation that goes deep into where the actual individual is being served, right? So there's those two components, and within both of those, leadership matters. That's one, you can't do anything without engaged, supportive leadership, and that needs to happen over time, not just, oh, this is the new fun thing and I'm going to move on 6 months later. Redesigning the systems. If you think about ACLS as an analogy, it's a very systematic process where the people know their roles. They know what they're supposed to do at the time they're supposed to do it. The meds are available, the crash cart's available. It's measured, evaluated, and changes based on measuring that process, that system. And then we've been talking about the team, defining the roles and responsibilities, who is on that team and what is their role, the community engagement, what messages are working with individuals in the community that you're working with, what messages work with the providers, the care team. And then that leads to the measurement piece of it. And I would advocate that you need both implementation measures to measure that process until you have it hardwired, scaled, and sustained, as well as the longer term outcome measures. And I want to give time to my colleagues here, but I do want to advocate for, I know the public comment period is open for the NQFs being heard and understood measure. I think it's an incredible measure. We're fully supportive of that. I thank Tori for being a key player in that measure. I also am putting a shout out. Diane and I talked about this not too long ago. We hear experiential evidence of the individual's experience in having quality advanced care planning conversations, and it can be life-changing. It's powerful, it's profound if it's a skilled conversation, and it continues over time as their goals change. I've not seen any research, and if it's out there, let me know, but I'm looking for researchers that want to elevate the voice of the individual in this experience through this evidential, this experiential, anecdotal Every organization we work with, they tell these stories, they have these testimonials, and we're not capturing that in how powerful this work is. And it can be from working through a 5 Wishes document on their own. It could be a digital online experience, it can be in person, again, multimodal, but they're all having, not all, but I'm hearing so many having such a profound positive experience in engaging in quality advanced care planning conversations. So I'll conclude with that shout out and ask.
I'll share that Dr. Lauren Van Scoy from the University of Pennsylvania at Hershey has actually performed this research repeatedly in partnership with an organization called Practice in evaluating these tools for advanced care planning in the community, particularly in underserved areas. So there is evidence and research out there. It's just not widely disseminated about consumer empowerment and how people feel about making care decisions as a result of advanced care planning tools and resources and these types
Tori,
of conversations.
can you repeat the name of that organization real quick? You blurbed out on my audio a little bit. Can you just repeat the name?
Of course I did. The researcher is Lauren Van Scoy from the University of Pennsylvania at Hershey, and their partnership was with Common Practice. They created the Hello game.
Thank you.
I absolutely, and I agree wholeheartedly with Stephanie. I think that the way that I think about measurement is really around structure, process, and outcomes. So in terms of the structure, I think it is important to track routinization of this type of event and care planning. And I think there's a lot of movement in this direction from on the federal level, requiring advanced care planning as a part of models, as a part of ACOs, as a part of other value-based payment arrangements, so that these things actually are documented and collected. And that can be a count, that can be a start. That just says, how often is it occurring in the workflow? The process piece, as Diane, as you were sharing, is really around, was care changed or impacted? And you can really measure that through referrals to other things or other services. And advanced care planning is a great start to really understand what people need from the overall system or the system at large. And there have been a lot of innovative models of tracking what the outcomes are from advanced care planning once that's initiated, to determine if somebody gets more or less of what they want or things that are available. And Highmark is the Blue Cross Blue Shield plan. They are the leaders in this, really evaluating and measuring advanced care planning as how was the system changed and was the care impacted. And I think ultimately all of that work came out of the value-based insurance design project that they've had, where advanced care planning is a requirement for any VBID participant for Medicare Advantage. And we have a lot to learn from those participants there in how they're tracking and measuring things. And then on the outcome side, I completely agree around the heard and understood measures, which is really around how can we measure the patient reported experience or the patient reported outcomes? Because you can't change everything, especially if the underlying system is broken already. But what you can do is help ensure that somebody feels heard and understood, and that the trusted relationship between the person and their care team is at least intact through having these conversations. And to me, that is an end in and of itself. Even if they change their mind, even if they can't get everything they want, we can't fix a broken system just with advanced care planning. But what we can do is help build that trusted relationship and be that ongoing guide for someone. And now we have actual measures to be able to evaluate that. And while the NQF measures are about heard and understood in the seriously ill population, I think there's a real opportunity to test out these measures in a more well population, in an ACO type environment or a population health approach, because those are the things we want to measure. We want to measure how empowered our consumers are, and if these conversations make an impact or a difference there.
I love that focus, because I think there's been so much attention with advanced care planning in looking at, and not that there's anything wrong with this, but looking at reduced costs. And I think those are important, but it doesn't ever tell me how did the care go. So I really appreciate the importance that you're giving, and you're underscoring the need to ask the people that we serve how this went for them. That I think it reminds me of NHPCO, the old FEC survey used to have these confidence questions. Do you remember those that went out to bereaved families that would ask them questions like, how confident did you feel in providing care for your loved one? And how confident did you feel in doing these tasks? And I think things like that really help us understand, did we do what we meant to do? And I like what you're talking about with moving to measuring some of those things. And I'm hoping that the system leaders who are on with us today are hearing that, because it is possible. You can measure more than completions and number of conversations. And I hope that people will, because those are really not outcomes, they're outputs. And they don't tell us much. And that's kind of the problem that got us to the conversation we're having today. It's a big topic, but I want to, before we close, spend a couple of minutes at least talking about kind of related to asking people what worked for them. How can healthcare providers better involve all of the stakeholders in advanced care planning? Because the truth is that people are doing it without us. They're doing it in their communities. They're doing it in their families. They're doing it with lawyers. They're doing it with financial planners. So how can we better involve all of the stakeholders in what this is and how we build systems to support it and how we measure it? And it's an open question.
I'll go first. I will say that, I think anybody who's been in palliative care practice, this has happened to them, where we see the patient during the day. It's during normal business hours, but the adult daughter or son who lives a few states away or was at work during the day was not part of the conversation. And so you're speaking to them after 5 p.m. when they're free to update them on what you said to mom. So we do this evenings and weekends. Everybody joins, everybody hears the same information, everybody gets to ask their questions. And I think that to do really high quality advanced care planning, you have to get the spouses, the adult children, the people from their faith community, their neighbors, whoever their caregivers are, whoever they want in their tribe here to be part of this. And the delivery system that we have in place, where it's 8 to 6 p.m. Monday to Friday, just does not work for most people. And so I think that we've got to do this on the patient and family's time, not on our time.
And I would add, I love the idea of stressing the importance of being united in purpose, in the same way that we have to let our patients know that, here's why we're asking you this question, and it's to provide the best care possible and know what's important to you. That's the same message that needs to go out to the faith communities and workplaces and everybody who's flying an advanced care planning flag. If we're united in purpose, people will respond to that, I believe, and we've seen it. And I think what we've seen over the past 10 years especially is that things like making advanced care planning reimbursable is a discussion. The VBID options that Tori has talked about, these have all been helpful things, but they haven't fixed everything. And so if we add to those helpful things, outreach on the part of health systems, not from clinicians who don't have the time to do that, but from others in the healthcare system who are educating the community, working with workplaces and faith communities and other existing communities, and helping families have these conversations on their own, and then be able to circle back and make sure it's documented and known within the health system. What I've seen from my own experience in the people that we've worked with and in our own family is that the magic with advanced care planning often happens when the person leaves that consultation in the car home, when they're talking with their spouse or their son or their daughter. So helping them be empowered to do that, I think is key, and united in purpose.
I think that's very well said, Paul, and thank you for that. I'm going to leave that as our closing words. Thank you. Thank you so much to all of our panelists today. This has been, I think, a wonderful and productive and meaningful discussion, and I look forward to continued dialogue and partnership with all of you. And thank you again to everybody who's joined. And with that, I'm going to hand it back over to our facilitator, Jennifer. Thank you.
Thank you, Kathleen. We did record this session. We will have the archive available within 7 business days. You may access the recorded archive by visiting the 5 Wishes Practice Community page at 5wishes.org/practice, and just look under webinars. Do feel free to share the page and webinar link with your colleagues. On behalf of 5 Wishes, thank you, of course, to our wonderful panel and everybody for joining us. Have a wonderful day.